To me, the primary indication of doing a joint replacement is the quality of the life that the patient wants to lead.
So we don't use a one-size-fits-all approach.
I think every patient's different. Everyone's recovery is a little bit individualized, so to speak.
So there are a variety of options for our patients who come in with arthritis that don't have to be surgical in nature. Sometimes it might be something as simple as an exercise program or some physical therapy. We can use anti-inflammatory medications, which can be either the over-the-counter variety or prescription variety. We also have injections such as corticosteroids for the knee. We have lubricating injections, which are made of hyaluronic acid. And there are some other injections that are available that may not yet be quite mainstream, things like PRP injections and stem cell injections. And some of these things can be used for both hip and knee arthritis.
Sometimes I'll find that if they do a little exercise to strengthen the joint, that can help with physical therapy, things like that as well.
Yeah, I think those are all good options. And one thing I would add too is some patients like to use some braces. So sometimes a brace that can shift pressure from one, maybe the bad area of the knee to the good area of the knee. Sometimes patients like to use braces while they're at work or doing activities such as golf, tennis, or other sports. Some patients also use a cane or a walker to help offload some of the pain from the diseased hip or knee. What I'll tell patients is to be eligible or be a candidate for a hip or knee replacement procedure, they have to meet a few criteria. The first of which is they have to have bad enough arthritis. We don't want to do a hip or knee replacement for a patient with mild or even moderate arthritis. So we want to make sure that their arthritis in their hip or knee is severe or sometimes what we'll call bone on bone. The second category is they have to be healthy enough for the procedure. So we'll have them see their primary care physician. We'll make sure that all their medical conditions are well managed and that medically they're healthy enough to undergo the surgery itself, the anesthesia, and the recovery. In addition, the patient also has to be physically fit enough to do the recovery after surgery. We do hip or knee surgery now, and we ask our patients to get up a few hours after the surgery, and they have to have the function and the stamina to participate in the rehab that's required for it.
To me, the primary indication of doing a joint replacement is the quality of the life that the patient wants to lead. If they've tried some non-surgical treatment and they're finding their pain level or their activity level has declined enough that they feel that they'd like to proceed with the surgery, then they could pursue it. But it is an elective procedure, and no one has to have a replacement. It's really the patient and the surgeon determining when it's time. I think the primary benefit of people having an artificial hip or knee is that they're taking something that's a burden for them, either through activity decline or for pain. Some people can't even sleep at night. And by having the procedure, it can improve their function and improve their pain. So instead of a burden prior, it becomes more of an afterthought when they're through the healing process. The primary risks, there's some risks that are universal to any lower extremity surgery. Anesthetic risks of spinal or general or some of the various nerve blocks we use. There's a risk of infection anytime that you make an incision on somebody's skin, that's got to heal. There's risk to the nerves and arteries, from relatively minor things like a little numbness around the incision all the way to weakness that can occur in the lower extremity. And lastly, there's risk of blood clot.
I think those are all good points, and we have a lot of things in place to have that safety net for the patient. We have nursing who you can call during business hours. We have surgeons and physician assistants who staff our after-hours phone line. So there's a lot of ways to reach us if you're worried about one of those issues. I think one of the benefits to having hip replacement with ProHealth is all of our surgeons do a lot of hip and knee replacements. And we know that the more of these procedures you do or specialize in, the lower your rate of complications are. So I think doing the same procedure over and over helps to reduce the risk that something bad could happen.
An anterior approach is when we make a small, about a 4-inch incision over the front part of the thigh and hip. When we use that approach, we're actually able to gain access to the hip simply by spreading muscles and muscle groups apart without having to detach them from the bone. And we found with that approach, it probably leads to less physical discomfort immediately after surgery, a more stable hip that has a lower risk of dislocation, and an easier ability to manage the limb lengths and to get those as precise as possible. So my default approach is to go with an anterior approach, but we do have some patients that may have some changes in their skin or some excess tissue in the front part of their hip in their belly that may not make it the perfect approach for them. So we don't use a one-size-fits-all approach. We will obviously assess the patient and use what approach we think is most appropriate.
I think it also has led to patients being discharged from the hospital sooner and sooner. Mm-hmm. Patients used to stay maybe two days, 3 days. That shortened up to 1 day. And now some of our hip patients are leaving the same day because those muscles are left intact and can function much sooner than maybe with other approaches.
The knee replacement parts that we're using really haven't changed much in the last 20 or 30 years. There's better plastics and things probably wear a little better, but the knowledge of how we're putting these in and what we can do to control people's pain has made more advances than any new implant design that I've seen.
The knee replacement concept is still the same. We trim out the arthritis and bone spurs and give them a nice stable knee that hopefully will be pain-free for the rest of their life. But we have modified some of the things we do before, during, and after surgery to make it more comfortable. Now we use some medications ahead of surgery to help with their pain during the procedure. After the surgery is done, we have our anesthesiologist place a nerve catheter around the knee that helps to numb up some of the nerves that give sensation and experience pain after the procedure. So when you're up and moving, or even the next 2 or 3 days, the pain isn't as severe as it used to be. We also use what's called a multimodal pain approach. In the past, we used to just give patients opioids or narcotics. Now we use a little bit of all kinds of different medications, some Tylenol, anti-inflammatories, maybe even a little steroid, and we try to minimize the amount of narcotic or opioid they would need after their knee surgery. So the way we do the surgery hasn't changed a lot, but the way we manage their pain afterwards has helped a lot.
Hips tend to get better a little quicker with maybe a little less effort on the patient's part, maybe a little less formal physical therapy as compared to a knee replacement. It's not uncommon for someone to be coming in with a walker, but hardly using it at that first 2-week visit after a hip replacement, but it's there as a steadier for somebody because they're getting used to their new hip. But when the hip comes in at a month or at 6 weeks after, many times they're looking great and feel like they've recovered most of the way. I think a knee replacement takes a little bit longer with a little more physical therapy. I'll tell my patients that the first month is pretty intensive. They're not going to be doing a lot of driving for the first couple of weeks as they'll be on some pain medications. They won't want to sit in a car for a long period of time, and they're going to get to know their physical therapist pretty well. But at about a month, they'll come in with some initial swelling from the surgery having decreased, and they'll be bending their knee to 90 plus degrees, close to full extension. More fine-tuning over the next month, and much of the daytime pain is gone at that point, but still maybe a little nighttime pain that lingers. And then at about the end of 3 months is when I think most people are getting happy with it. So I think hips a little bit quicker with a little less formal therapy and effort. Knees, a hard month, I would say, or a month that's more intensive, and then a couple months of fine-tuning.
Most of the recovery is done in that first kind of 3 months, but I tell patients they can even recover up to a year or year and a half later, as some of our studies show that as well.
No, I agree. I mean, I think that part of the challenge is when patients aren't progressing as quickly as they think they should, is to reassure them and to let them know healing is not done at 4 weeks or at 6 weeks or at 6 months for that matter. And as long as we're seeing continued gains that, like you said, up to a year, year and a half later, they can ultimately be at that point of maximal improvement.